Okay, chalo, we'll move on next to the properties of the cardiac muscles. Okay, now we had been talking about contraction. Was it all clear? Okay, now look at this particular chart over here. This will tell you how the contraction was happening. The action potential was leading to rise in intracellular calcium. Isn't it? Where was the calcium coming from? Calcium was coming extracellularly. It was coming through those T tubules and then it was being available inside. Isn't it? So once the calcium is available inside, calcium binds to troponin. Troponin C. Then once the calcium binds to troponin, tropomyosin that was covering the active sites on actin, it loosens and uncovers the active sites. Myosin binds to the active sites and the contraction of muscles take place. So this is all we saw. All clear? Okay, now we'll be talking about some more terminology. We'll be talking about isometric contraction and isotonic contraction. Okay, now what happens is, we already saw that myosin pulls the actin filament closer. Now we already saw that muscle can contract. Okay, and how the force is generated, we also saw that. Now, if by chance the force is generated and the muscle is trying to contract, okay, while contracting, if it shortens, it will shorten because muscles are pulling together. Then that kind of a situation is called an isometric situation. But imagine if the muscle is kind of tied on both the sides. It is trying to put the pressure, but it is not able to contract. But yes, it is applying the pressure still, isn't it? The contraction is actually happening, but it is not able to slide over each other. So that kind of a contraction is called as isotonic contraction. Right? So we'll be looking at it where isotonic contraction happens and where it doesn't happen. Yes, when it is able to contract, the work is done. It is applying the pressure, work is done, it is contracting. So that kind, it is isotonic. And isometric is when it is trying to contract but it is not able to contract. That kind, it is. Did I say ulta for the first time? Okay, I'm so sorry. Now when I'm saying that, I realize that. Okay, isometric, no work, no shortening. But muscle is trying to contract. Isotonic, muscle is contracting. And work is happening. Right? Now, there is a phenomenon called as Frank-Stirling's law that tells that if the end diastolic fiber length is more, the force of contraction is more. What does that mean? Now, what happens is, we all very well know when does the heart contract. Before the heart contracts, heart receives the blood. Heart receives the blood and it dilates. Once it receives the blood and at the end of the diastole, it contracts. Now if it receives a lot of blood, it is nicely stretched. Now when it contracts, the force of contraction is more. Why does that happen? You very well know, we had been talking about these actin and myosin filament overlapping each other. Isn't it? And what is contraction? Contraction is nothing but sliding over of these actin and myosin over each other. So if in the beginning, before the contraction, if the distance, if we are somehow able to pull those actin and myosin far away, when they contract, they will have more room to contract. Understanding the point? So if before contraction we are able to pull them apart, during contraction they will have more space to be pulled towards each other. So the force of contraction will be more. Isn't it? So that's what is Frank-Stirling's law. When it's clinically applied, it is like when the end diastolic volume is more, when the heart is stretched before contraction, the force of contraction is more. Okay, but there is a limit. There is a limit. We cannot stretch it apart too much, isn't it? It will tear off. There wouldn't be, we have to maintain. We can only stretch it apart till we have the myosin. We cannot stretch it beyond that. Before contraction, if we are trying to stretch it, we have a limit, isn't it? That is why we have this particular word here, physiological limit. So all this works within a physiological limit. So the length of a sarcomere is nothing but a muscle cell. Length of the sarcomere that is associated with peak force of contraction is 2.2 microns. Clear? Yeah, now there are two more terms for you to understand. Now these two terms are important for MCQs. One is the preload and second is the afterload. Okay, when we say preload, load that is operating before the contraction is a preload. Okay, so before the contraction starts, what is the load on the heart? It's the blood that is filled in the ventricles. Now when the ventricle will contract, they will have this load of the blood already there on them before it starts contracting, isn't it? So that is called as a preload, right? When it starts contracting, where does it pump the blood out? It pumps the blood out in either the pulmonary arteries or in the aorta. So it will open the valve and it will pump the blood out in the aorta or in the pulmonary artery, isn't it? When it has started contracting, the next resistance or next thing what it will meet is the blood which is already there in the aorta. Aorta is not empty, isn't it? It never gets empty, right? So when the ventricle are pumping the blood out, there is already some blood in the aorta or in the pulmonary circulation, and that already existing blood acts as a load. Load means a barrier, a resistance to the blood. Now, the action which ventricle is performing. That when does it act? It acts after the contraction has started. So that is called as afterload. Clear? Look at it. Preload, the end diastolic volume of the heart, that is the load which operates before the beginning of the contraction, is preload. Then afterload is the pressure of the aorta that opposes the ventricular shortening when the ventricle has already started contracting, is called as afterload. Afterload is not the blood. Afterload is a load created by the blood. Afterload is a load. It's a resistance offered. It's a load on the heart that it has to bear because, while throwing out the blood. Clear? So afterload itself is not the blood, it is the force. It's a resistance, yes. The force. Okay. So what did we see till now? We saw about the preload, the afterload. We saw about the Frank-Starling's law. Frank-Starling's law told us that if we have the nice stretched heart, it will contract more within the physiologic limit. How will we have the nice stretched heart before contraction? By having a nice venous return. That means if you have a nice end diastolic volume. End diastolic volume is nothing but the volume attained by the heart at the end of the diastole. Okay, so don't get confused when different terminology is used. You have to, imagine the heart as a simple, a chamber, elastic chamber that is receiving the blood and pumping the blood. Don't make it too complex. It's very straightforward. Okay, now that's one thing. Then we talk about the afterload and preload. All clear till now? Then you have something called as contractility. Contractility is the inherent property of the muscles. Okay, basically it's a change in the force and speed due to biochemical changes around the muscle fibers. So it is called as the inotropic state. It's because of the ions and all that, whatever, changes that happen in the contraction thing, that is called as the contractility of the heart. Okay, so herein that means it is increased force and speed of the contraction due to biochemical changes. Now there's one more thing to understand, that is Vmax. Vmax is, remember we have been talking about afterload. So I'll just draw the one chamber. Okay, this is one ventricle and this is one, aorta. Okay, I'm not drawing the whole heart. Now when the ventricle pumps, it has an afterload because of the blood in the aorta. Okay, now imagine if our aorta was empty. Imagine, okay. That situation doesn't happen. We are just defining Vmax. You have the slide now, Saurabh? Then refresh. Others, you have the slides? Saurabh, you need a refresh. Okay? You getting the point, guys? Yeah. So, if we imagine that there is no afterload, the blood will be pumped out by maximum velocity possible. Isn't it? That is called as Vmax. Now, Vmax actually tells you the property of the heart. It tells you the contractility of the heart. Because it is taking out into the consideration the afterload and it is telling you its inherent ability of the heart. Okay. So that means if a particular heart has more Vmax, it has more of a contractility. Isn't it? So when the Vmax is more, the contractility is more. Isn't it? So that's what is Vmax and that's what it tells. Now what are the factors that influence the contractility? We already saw when we talk about the contractility, it is the effect of the ions and all those things on the heart's capacity to contract. Now herein, acidosis reduces the contractility of the heart, alkalinity increases the contractility of the heart. Rise in temperature and tachycardia increases the contractility of the heart. Okay? Increase in calcium, adrenaline, noradrenaline, sympathetic stimulation, all that, they increase the contractions of the heart. Okay? So these are the factors that affect the contractility. That is the ionotropic state of the heart. Next, we will be talking about the conduction system of the heart. Remember, we have been talking till now. Yeah, in the list we saw as only the acidity is reducing it. Okay? Yeah. Next, till now we have been talking about the contractile muscles of the heart. We saw that there are two types of cells in the heart. One is the conducting cells and the second is the contracting cells. We saw about the contracting cells. Isn't it? We saw about the 4 fibers they have. We saw how they contract. And based on that we also learned about some of the nature of the muscles of the heart, like we saw about the Frank-Sterling's law and everything. Right? Next we are talking about a conduction system. When I say conduction system, here we are talking about the modified cardiac muscle cells. They are non-contractile. They have become modified and they have become specialized to conduct the impulses. Okay. Now again, these modified cells are of 3 types. One is the P cells, which are found in SA node and AV junctional tissue. SA node and AV junctional tissue. Okay. Then we have Purkinje cells. Purkinje cells are found in bundle of His. And then we have transitional cells which are found near SA node and are intermediate between the above 2 types. Okay, as we go on further you will be able to understand it better. Let's talk about the SA node first. What is SA node? SA node is an accumulation of pacemaker conducting cells. Where is it located? It is located just medial to the opening of superior vena cava. Where does superior vena cava open? Which chamber? Yeah, it opens in the posterior wall of the right atrium. Okay, now look at these small points. They are MCQs. So look at the location of the pacemakers. Pacemakers are located medial to the opening of the superior vena cava and the posterior wall of the right atrium. These cells depolarize. That means they fire. Shoot. You know the depolarization, right? That is nothing but triggering of an impulse. They depolarize at a rate of 70 to 80 times per minute. Okay, this is the one that determines the normal heart rate. That is the sinus rhythm. Okay, for this reason, SA node is called as pacemaker. Now, SA node is under the influence of the autonomic nervous system, but right now we are talking that SA node has a capacity to generate its impulse. Okay. Next we have AV node. AV node is located in the right atrium medial to the tricuspid wall. Where was your SA node located? It was in the right atrium, but in the posterior side it was just medial to the opening of the superior vena cava. Here and this is just medial to the tricuspid wall. Where is the tricuspid wall? Tricuspid wall is the junction of atria and the ventricle. So you can say if this is your right heart and this is your right ventricle, somewhere here your superior vena cava opens. Okay, somewhere here was your SA node and somewhere here is your AV node. Okay, this is your AV node and this is your SA node. Okay, now AV node receives a wave of depolarization about 15 milliseconds after it leaves SA node. We already saw that SA node generates impulses. SA node generates impulse and it sends those impulses to the AV node. Okay, but the passage of wave through AV node slows down and it takes about 3 times longer to pass through the node. So node is acting as a barrier. AV node was generating the impulse. It sent the impulse in 50 milliseconds to the, SA node was generating the impulse. It sent the impulse to AV node within 50 milliseconds. But AV node is such a lazy fellow. It is slowing it down. It is taking 150 milliseconds to let it pass through the node. This delay is crucial. Why is this delay important? Because the human body is designed such that atria should complete its contraction before ventricle contracts. So when the SA node's impulse is coming, it is in the walls of the atria. Atria is contracting now and AV node will delay the impulse. It will allow the total emptying of atria and then it will let the impulse go to the ventricles so that now the ventricles fire. Okay, so that's what the delay in the AV node is important. But what you have to understand, where does delay take place? Where is delay taking place? It's in the AV node. Okay, and that's an MCQ. Okay, after that we have the bundle of His. Okay, it receives a wave of depolarization from the AV node. This bundle, we already saw about AV node, SA node, AV node, and then we have this bundle of His, okay, that passes into the interventricular septum. Then it divides into right and left bundle branches. Okay, so here this is your bundle of His. It divides into right and left bundle branches, and then these branches, they continue to form the Purkinje fibers that carry the wave to every side, every corner of the ventricular myocardium. So that is how the impulse is traveling. The impulse is coming from the SA node. It is delaying at the AV node, and then it is traveling quite a bit fast at bundle of His. Okay? Yes.